Hello, I'm Mike Ackerman, Director of Mayo Clinic's Genetic Heart Rhythm Clinic and our Winland Smith Rice Sudden Death Genomics Laboratory. In the November issue of the Mayo Clinic Proceedings, you'll see our article entitled "The Promise and Peril of Precision Medicine, Phenotyping Still Matters Most." I hope you enjoy this article as much as we did in doing it and providing it for our readers of Mayo Clinic Proceedings. Unfortunately, it is a tale of two tales, and one side of the tale is not a very good one. What we show in this work is not only the promise of precision medicine through genetic testing, but the perils, and we are indeed seeing the perils rearing its head. The fumbles that are occurring with genetic testing out there in cardiology specifically, and I suspect throughout many of the disciplines of medicine, are starting to mount, and I think we need to do a major timeout and reassess what we're doing and how we're utilizing the genetic test and whether we're being wise users of the genetic test. What we show is that the clinical phenotyping, what we've always done as clinicians, really matters the most. How do we illustrate this in this special article? A family, a very special family, endures what I see in my practice all too often, a tragedy, the tragedy of sudden death, taken at a young age as a teenager, seemingly inexplicably. The child gets an autopsy performed. The autopsy seems to be unrevealing, although the medical examiner noted that the heart was thicker than normal, that there was myofiber disarray, but is yet not willing to assign a phenotype, so renders the sudden death unexplained. The well-intentioned cardiologist now responsible for taking care of the rest of the family follows the national and international standard of care to do cardiac testing. In the course of that cardiac testing, concludes that the living brother might have something wrong with his heart, and since he's related, he or she performs genetic testing, cardiac genetic testing, channelopathy genetic testing, and it comes back positive, or seemingly so. Equipped with this, the conclusion is made that this is a family of autosomal dominant type 1 long QT syndrome due to a missense mutation annotated as V133I in the KCNQ1 encoded Kv7.1 potassium channel. That may not mean much to most of you, but what it meant to the caring physician was this child is mutation positive. Therefore, that must have been what was the cause of sudden death for his brother. Not to let it happen again, an implantable defibrillator was installed. And now the rest of the story. Surrogate genetic testing of a living in the absence of a phenotype is dangerous. And it was misleading and erroneous. Ultimately, the family came to Mayo Clinic for a second opinion. None of the living individuals who showed that marker in the genetic test exhibited a clinical phenotype to suspect the presence of long QT syndrome in general, and let alone LQT1 in particular. We became very doubtful that this was the cause, and in fact there was a blood spot card obtained on the decedent, yet that wasn't submitted for genetic testing. Instead, the living was. We tested the decedent for that thing in KCNQ1, the thingamabob. It was negative. The case is unraveling. The wrong way of doing genetic testing can lead to the wrong conclusions. No clinical evidence among the living for long QT. The decedent doesn't even host that KCNQ1 thing. So now what? Well, with this information, we needed to mount additional evidence because the well-intended physician was simply reading the genetic test report. It said probable deleterious mutation. What do you do with that interpretation? Well, we rewound the clock and we put the proverbial jack back in the box by doing functional studies and showing that the Kv7.1 potassium channel didn't care whether there was V at position 133 or isoleucine at 133. So now we have to return to the search for the root cause, and we show what's the right way of doing genetic testing. The right way, focus on the one who actually has a problem, called the sudden death victim. So with that blood spot card and with the normal parents whose cardiac tests were all normal, we performed what's called a whole exome molecular autopsy, a WEMA. And we subtract everything that the decedent inherited from the mother and father because we went under a presumption of a possible de novo mechanism, because there is no story in the family. The story is singular, the tragic sudden death of this young adolescent male. With that mindset and with that approach, what we discovered was the cause, a sporadic de novo mutation in a gene, DES, that encodes a protein, desmin. In this case, things were made rather easy for us because that specific mutation had been previously characterized, previously functionally studied, established as a pathogenic cardiomyopathy mutation. And in fact, if we go back to the autopsy report itself, the child, the decedent, had evidence for a cardiomyopathy. The heart was heavier than it should have been, thicker than it should have been, with myocyte disarray and evidence of scar, all fitting with desmin-mediated cardiomyopathy. So we have the wrong way of doing it, surrogate genetic testing among the living, and failure to correlate the genotype and the phenotype, and the right way of doing it. Had we started with the right way of doing genetic testing, the promise of precision medicine would have been fulfilled, and fulfilled rapidly. Clarity and closure, an explanation as to the reason, the root cause behind the decedent's sudden death. And clarity for what it means for the rest of the family, at least for the rest of the family. Good news, no one else is at risk because no one else has it. As opposed to the situation at the beginning, a seemingly undiscovery of a large family where over 24 family members were erroneously diagnosed as having long QT syndrome. Hopefully you see in this special article the right way of doing genetic testing and the wrong way. We, the users of genetic tests, need to be wiser interpreters of the genetic tests. We need to be wise users of it in the first place. Shouldn't have been used in the living as a surrogate when it should have been focused on the deceased. And then when we get a genetic test result, we need to be wiser interpreters. We can't just acquiesce the responsibility to the gene test companies and take their report verbatim. They're doing their best, but their insight into the significance of a genetic variant is limited as well. What they, the gene test companies, lack, which is something we possess, is the phenotype. And we have to be sure that we're correlating the genotype and the phenotype. I hope you've enjoyed this article. One of the reasons why I've enjoyed it so much is because the discoverer of the root cause, the sleuther, if you will, was not only my lead scientist, David Tester, but my firstborn son, Jager Ackerman. So hopefully this has been something that you have enjoyed reading and you've learned as much from as we have in doing it, and I wish you all the best. Thank you very much.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.